Good afternoon, my colleagues. First of all, thank you for attending the session. Thanks for Hikma Pharma for inviting me for this symposium. And teldracizumab in psoriasis, we need to know what's new. I think we have almost 12 biologics available for psoriasis patients. And I think psoriasis patients are very lucky that we have all these treatment options. And we, as a dermatologist, are privileged to understand the differentiating point between all these medications to choose the best for our patients. Teldracizumab is not a new product. It's an old one in the market, but we always trying as a medical education to present what's new for the profile of the medication. So we need to understand better and to differentiate this molecule between the available treatment options to know how to choose the best treatment for our patients. So I will start with my disclosures, and one of the new posters has been published in the American Academy of Dermatology that happened earlier last year, and talking about the difficult to treat areas and maybe the time to change the concept, because here in this poster they are highlighting that the difficult to treat areas may be not difficult anymore, and even in the recommendation they are advising us to change the term to the sensitive areas because most of the available treatment options are doing a good job in this area. And what we learned earlier, that maybe IL-23 cannot be the best to treat the challenging patient. However, here they have a proof by discussing this positive trial, which is an ongoing 24-month trial, a phase 4 observational trial for teldracizumab patients, and they are trying to measure the effectiveness of this molecule in the patients who have what we are calling as a difficult to treat areas, either the scalp or palmoplantar or nail psoriasis, to see how the medication is working in this population. And during this population, we have almost 28 to 29% of the patients, they have a scalp involvement. We have 75%, they have palmoplantar involvement. They have almost half of the patient, or even more than half, have nail involvement. And you'll not be surprised to see that teldracizumab did a good job in all these patients by having a significant reduction in the scoring system of all these difficult to treat as early as week 16, with a sustained result until the end of the study, which we have it up to 52 weeks, despite the severity of the IgA level in these either scalp or palmoplantar or nail psoriasis. And also, while comparing this population for the patients who received the medication in 16, 28, 52 weeks, the more you treat, the more you gain. So with the continuation of the treatment, the percentage of patients who have a clear, almost clear skin is getting high and high with time. That's why they concluded that in this, as per the data presented in this trial, that teldracizumab can be effective in treating difficult to treat areas. And even, as I mentioned earlier, they are recommending that we may be the time to say it's the sensitive areas because it may not be difficult anymore and the patients can responding very well to the treatment options. Another poster published, they are measuring the outcome when it comes to the quality of life of teldracizumab in the patients who have severe psoriasis, comparing the population in US versus the population as a non-US countries to see how is the medication working in a different patient profiles. And the objective is to measure the effectiveness. And we mean by the effectiveness here is to have all these parameters, the absolute BASI, the PGA, and the body surface area, and also the DLQI. And we're not surprised that the medication is doing the same effect or the same effectiveness in all these different patient profiles. So either the population inside US or outside US, we still have a very good job. And they conclude that teldracizumab can be a very good option for any patient licensed to have a biologic therapy candidate to be moderate to severe psoriasis, whatever the location and also whatever the patient profile. Another poster talking about the burdensome symptoms and the overall well-being. And now it is the time to talk about the cumulative life course impairment, and having the signs and symptoms and the quality of life impact is always crucial for us to choose the best medication working well in this area. And again, that has been highlighted from the positive trial, which is again 24-month observational phase 4 study for teldracizumab to measure all the signs and symptoms of the quality of life when it comes to the itch, the pain, the joint pain, the fatigue, fatigue, again, as early as week 16, we have a significant improvement in all these domains, and all the patient-reported outcome has been improved significantly with the treatment. They conclude that IL-23, specifically tildrakizumab, can be a very good option if we need to improve the signs and symptoms, which may affect the quality of life of the patient significantly. Another poster talking about the IL-17 exposure, the prior IL-17 exposure to these patients. Do we think that tildrakizumab can be a good option for these patients or not? In terms of the adherence and the persistence of the treatment, and also in terms of the improvement of the better outcome than that the patient was reported during the IL-17 therapy. And here, the objective is to study the effectiveness, the persistence, and also improvement in the score compared with the previous exposure with the IL-17. And the study population was the patient who used the IL-17 for the last 6 years, from 2018 till 2024, regardless the reason of discontinuation. And the results showed that most of the patients, at least, they are sustained on the treatment at least for a year after they start the tildrakizumab. And again, not surprisingly, that all the parameters of the BASI scoring and the DLQI and the IgA is also getting better with the treatment, and they conclude that tildrakizumab can be a good option if the patient stopped IL-17 inhibitor earlier. Either we talk about safety issues or even we talk about efficacy issues, as per the data that the patient can be sustained in the treatment, adherent to the treatment at least for a year, and also the efficacy outcomes looks better before what reported in the IL-17 molecule that has been tried earlier. Another thing, talking about the treatment pattern when it comes to differentiation between the other IL-23s. We know that we have risankizumab and guselkumab, and also we have the ustekinumab and IL-12/23, adding to the family of 23 blockers. So here they are trying to measure, again, the treatment continuation and discontinuation and the shifting and the adherence of the patients on all these IL-23s together for the duration started from 2018 up to September 2023. And again, you will not be surprised that tildrakizumab was the higher rate of persistence compared with the other IL-23 blockers. So the adherence to the medication was reported to be the higher compared with the other IL-23. And I think one of the most important reasons is the convenience, because tildrakizumab have the least number of injections that the patient will be received during the treatment course, if we are talking about an annual course. And the conclusion here, they very clearly mentioned that tildrakizumab associated with a long persistence compared with the other IL-23s, with also the lower discontinuation rate. Another one talking about the drug survival compared with the other biologics in the psoriasis registries, the core Evitas registry. And here they are trying to examine the characteristics, the effectiveness of the drug survival for the patients who started tildrakizumab, specifically for the patients who have an obesity. So because you know that the obese patients will be having a problem with the continuation of the treatment because of the success rate. And out of almost 700 patients treated with tildrakizumab, half of them was having a significant obesity, which is defined to be MI 30 and above. And they need to compare all the outcomes for this population. And surprisingly, again, that we have no significant difference between the obese and the non-obese patient in terms of treatment discontinuation. All the patients were then adherent to the treatment without any kind of signal that the obese patient will discontinue because low efficacy or anything like that. So patients are continuing the treatment because of the medication is doing well in both obese and non-obese patients. And also when it comes to the persistence of the therapy, and also when we will see that the difference in the outcome almost very close together. We may have a little bit difference when it comes for the non-obese patients because basically we have the same dosage, but also the obese patients, the medication in terms of efficacy did a very good job, and they concluded that the results from this real-world evidence indicate regardless of the baseline obesity, patients are on the medication, continuing the medication with improving in their outcome. Another poster talking about, again, the obese patients who have a scalp psoriasis. Do we have a difference in the response when we have a two challenging point here? Because we know that the scalp psoriasis is considered a challenging point, and also obesity is a challenging point, so they are mixing both together to see how the medication is working. And again, you will not be surprised that you will not see a significant difference between the obese and the non-obese in terms of tildrakizumab treatment. Either we're talking about the IgE for the scalp, or we're talking about the BASI 90 for the scalp, psoriasis scalp index 90. Also, you don't see a significant difference, which means that adding more challenges doesn't affect tildrakizumab efficacy for these patients. Also, the change from the baseline in the NRS score, patient is obese or non-obese, always we have the same efficacy data that we have. When it comes to the safety, I think IL-23 blockers and tildrakizumab, you cannot compare any other medication or class with the same safety profile, because the discontinuation rate will be a very limited compared with other classes maybe, so we don't have any problem with the safety issues. And they conclude that tildrakizumab results in a consistent efficacy without any safety concerns for the patient who continue with this. So while we are presenting any kind of real-world evidence, we need always to have a practical translation to this. I told you that Tildra is not a new molecule. We have it since many years, even outside UAE, but again, we need to have the most newer data that has been published in the last international conferences last year, and now we need to correlate this with our clinical practice by sharing this case. He's a 37-year-old Indian male patient, have a history of psoriasis for almost 5 years. He have a widespread excoriated plaques, and patient have a significant itching, significant psychological comorbidities because of the disease progression, and unfortunately, patient have a latent TB during the screening. And again, you will be a bit scary when you choose which class when you have a patient have a TB. I know that most of the newer medications are considered safe in this population. However, also we need, when we have an Indian patient with a latent TB, we always need to be sure that you are keeping his TB silent. So patient treated with topical treatment, failed on phototherapy sessions, and he doesn't have any history of systemic treatment, and biologic therapy has been decided to start after the patient received the TB prophylaxis as per the guidelines. So this is the photos before the treatment. So we are talking about a patient have a widespread plaque psoriasis, kind of severe somewhere. We have excoriated plaques, we have evidence of itching, we have very thick plaques everywhere scattered all over the body. So again, it's a bit difficult job when we have such patient. Long disease duration, latent TB, so all this we should put it in our mind while we are considering the next treatment option for the patient. So tildrakizumab Olumiant has been selected, and again, we need to emphasize that we have the least number of injections when it comes to today after 1 month and then every 12 weeks. So almost talking about 5 shots in the first year. And after only 1 injection, which we usually not comparing any of the available treatment options for, especially for the IL-23 after only single injection, but at least we start to see some results. We start to have a healing of all these excoriated plaques. We start to see softening of the plaques. So the patient itching stop, the healing is completely done, and we don't see any thick plaques as happened in the baseline. With the continuation of the treatment, at least the patient after 2 injections, we can say that he improved, at least achieved the BASI 75 response. And when we compare the photos before the treatment and after 2 injections, we have a clear evidence that the medication worked well in the patient for this duration. And again, 2 injections, just patient came today, and then after 1 month, before giving the 3rd injection, the patient have this result. So at least you achieved a BASI 75 response in this short time after only receiving this injection. Considering that this is a challenging patient with a long disease duration, with a severe disease in the baseline, with also considering the TB positive and the latent TB, so all these are added more challenge to the patient profile, and we have these results. At least we have a 75% improvement. So I think we are here today to just focus on our molecule that talking about one of our game changers in psoriasis treatment. And we have new data has been presented when it comes to difficult to treat areas, when it comes to adding more challenge of the scalp and obese patients, drug survival, a good data with IL-17 exposure, and also all this has been practically translated with a clinical experience. So I think our patients are very lucky, and we are privileged that we have these multiple treatment options for our psoriasis patients. And that's why we are calling ourselves that we are able to change the patient lives once we have all these new initiative medications in our hand. With that, I'd like to thank you very much for your attention. I don't know if we have any time for any comment or question, or that's it. Thank you very much. Bye-bye.